Hi, I want to talk to you directly for a moment. If you're a primary care clinician and you have ever thought, maybe I need to change jobs to earn more, I understand. I've been there. It's very easy to assume that income growth means leaving your system, switching to another organization, going concierge, adding more shifts, working longer hours. But here is what most clinicians don't realize. In many cases, you don't need a new job. You need a new structure. Before I explain further, let me introduce myself. Hi, I'm Dr. Gani, a primary care physician of 20 years based in Boston. Now, let me continue my conversation with you about this topic. Primary care income is usually influenced by three things. Number one is your compensation model. Number two is your documentation accuracy. And number three is your schedule structure. Not your intelligence and not your dedication, not even your compassion. Structure is important. If you're RVU-based or productivity-adjusted, the way you document and capture complexity directly affects your income. You see, many primary care clinicians are managing hypertension, diabetes, hyperlipidemia, obesity, mental health, preventive care, medication adjustment, lab interpretation, all in one visit, but they're documenting and billing like it's simple, not because they're careless, but because no one trained us to think strategically about revenue capture. The second major factor is scheduling compression. When you pack your day with 20 to 50 minutes visits, you don't have time to address multiple chronic issues, capture preventive services, document complexity, reduce unnecessary follow-ups. Ironically, shorter visits often mean lower per visit revenue. In my case, when I extended my visits and became more intentional, something unexpected happened. I saw fewer patients per day, but I captured more appropriate complexity per visit, and my income increased without adding hours. The third piece is preventive and transitional services, annual wellness visits, annual physical exams, behavioral screenings, transitional care management. Many providers either skip them or separate them inefficiently. When structured properly, they significantly increase revenue per panel, not per hour worked. And this is important. This is not about overcoding. This is not about pushing unnecessary services. It's about accurately reflecting the work you are already doing every day. Primary care is high-value medicine. When documented strategically, it is financially sustainable. Now, let me be clear. This won't apply the same way if you're fully fixed salary with no productivity component. But if your compensation is even partially tied to RVUs, panel incentive, quality metrics, or productivity, there is usually untapped opportunity there. Most physicians don't leave jobs because they hate medicine. They leave because they feel financially stuck and emotionally drained. Before you assume you need a new contract, a new system, or a new city, ask yourself, have I fully optimized the structure of the job I already do? Because sometimes the income ceiling is not external, it's structural. I increase my income not by changing my job or my city, but by changing how I practice within the same framework. And the most powerful part, it didn't just increase income, it decreased my burnout. If this resonates with you, stay here, because primary care can be profitable without sacrificing your life to get there. You don't always need a new job. Sometimes you just need a better model instead of the one you already have. If you'd like to learn how to do that, I will be happy to help. You can join my channel and watch more videos like this, or go even further by clicking below on the resources I provide. I wish you further success in your career and a great work-life balance.